they were warm for the entire bath. We pulled out one arm, talked to them the whole time, smiled, rubbed their hand, washed one arm, put it back in. Now, that was the bed bath, but this also works if we're talking about showers. I mean, at one point with my father, he couldn't remember my mother, so he got very, modest. And so we'd put him in his swim trunks, put him in the shower. Mom would be in her bathing suit, and that's how we gave him a shower, so he did not feel like he was being exposed to everyone. And so, we just have to take a step back sometimes and think out of the box on how we can get some things done with them. Sorry for the tangent. That happens. Just pull me back in. But we'll move on to the next slide. So yay. Okay. So my are usually interactive. And so the more that you guys answer, the faster that we'll get to move along. So we're going to play a little game, and I'm excited, and it gives us a little break from hearing me talk. And so first question, and please put it into the chat, and Rick will read it off. And as soon as we get enough responses, I'll move on to the next one. So true or false, dementia and Alzheimer's is the same?
Well, we got a mix, false and true.
Oh, wait, I'm going back to the wrong. Okay, that's okay. Keep going, keep going. Okay, and then I will give the second one is, what is the greatest risk factor?
Okay, so the first one, mostly false.
Okay.
You want me to call them out as they come in, or wait?
Yeah, you can just group them up if you want. Up to you, Rick. However you want to do it.
Everyone's saying age.
Yay!
You're a winner on that one.
Okay, is this a normal part of aging? It wasn't clear the way I wrote it on there, sorry.
You won on that one too. No, false.
Yay, for those saying false. And I'll jump back to the first one. Dementia and Alzheimer's is not the same. Remember, dementia is the general term. It's a general term, an overall term covering specific disease. And so Alzheimer's is the specific disease. Dementia is a cluster of syndromes. It's the umbrella term. Think of it like cancer, right? Somebody has cancer. What type of cancer? Leukemia, lymphoma, blood cancer, skin cancer, right? Or like the type of flowers. So, all right, and the last one, so we can move on, is name a myth. Myth.
Taking longer to answer that one. There we go. Don't understand what's going on. Hereditary. Stand and salute. Only older people get it. There's a cure. It's genetic. Oh, not. Now one of them says it's genetic. Or let me go back and see if I'm reading that right.
Try saying not genetic.
It's genetic, hereditary. You got some answers on that. People with dementia don't understand what's going on. It's normal aging. It's reversible. Alzheimer's is part of aging. One gets it from the relatives. Not normal. Contagious. Only older people get it. Running in the family. Even younger people can get it.
But you guys are good.
They are.
That tells me that I like this because it lets me know if I'm explaining things correctly too. So yay, everybody. You guys are awesome and on it. Okay, we're going to move on to the next slide. And this one, I just want to show you really quickly. So these are the 10 ways to love your brain. And this is from the Alzheimer's Association. Just Google 10 ways to love your brain, ALZ. It'll pop up. If it doesn't, my contact info, it will be at the end of the slide. And you can email me and I will send it to you. But people ask, how can I decrease my risk? Well, here you go. Here's the 10 ways to do it. So of course, things like stop smoking, right? We saw that under the modifiable risk factors. Sleep is definitely something to do, something that I'm working on, but I'm getting there. So your brain can rest and relax. Fuels in the diet, which we kind of talked about. Following, like the heart diet. And then, what I like about this one is like hitting the books or stomp yourself. So what we're kind of talking about there is like, if you love music, we want you to keep playing the guitar or reading music, but we also want you to try and do something outside of your comfort zone. Like just learning another language, something kind of that you don't do every day, right? Like I love reading about the brain and Alzheimer's, it's just great, and I need to keep doing that. But then I need to go read about something else too, like destinations or food or just something else to get other connections in the brain going. And so that's kind of what we're talking about. Crossword puzzles, a lot of people like to do. Sudoku, there's mixed, that we're not going to go into the studies on that on this one. But or a lot of people recently, a lot of the kupuna have been signing up to take classes online. Like Manoa, they have that extent. I think it's called Extension Ed. Don't quote me, but they do have classes where you don't have to get a grade. You can just take the class to take the class, or if you do want certain ones that are in the regular schedule, you can just take it for credit or no credit. And so a lot of them have been returning just to learn new things. So it's a lot of fun. Budding up is fun too. So you want to maybe do it with a partner or with a group. And then, of course, break a sweat. And I always love to stump yourself because my mom is like an avid card player. And so she's always playing cards with us, or like backgammon. Most people my age don't know what backgammon is, but I can play that. And so I thank her for teaching me those kind of things, but it's fun. Okay, symptoms. A lot of people are going to ask the symptoms. We got a whole bunch of symptoms on here. I don't want to take up too much time going over all of them. These is not the entire list. But of course, the short-term memory loss, that's usually, when most people are bringing in their loved one or their friend in to come and see us, right? Mom isn't remembering things. She's asking me the same questions over and over. And so that's usually when that comes in. And I'm not sure if it was on another slide. No, I'll talk about that on another slide. Also, communicating, we're talking about how they lose their ability to with language, the visual, spatial, right? Inability to like recognize their faces or things in plain sight. The planning and prepping of meals, appointments, traveling, problem solving. So a big thing that people start to notice is that they've been missing appointments. Mom, I told you that you had the doctor's on Friday. How come you didn't go? Didn't you remember that there was this party? Or that they're not paying the bills, right? That they finally somebody realizes that the electric is turned off, or the mortgage is backed up, and they're trying to figure out why, or the checks haven't been written, or the checks, unfortunately, there are scammers and checks have been going out, into another area. And so that's where a lot of time, that's why I wrote kind of the list this way, this is when a lot of people are starting to notice these kind of things, and that's when they bring them in. The confusion I wrote here is because people with dementia live in a state of confusion. And what do I mean by that? So have all of us have been confused, right? You walk into a conversation and you're like caught off guard because you like jumped in the middle. You have no idea what's going on. Your head is just kind of going back and forth. Or someone starts the conversation with you and you're like, I don't understand how we got to this point, what's going on. Or you're trying to find a place and you're going around in circles, and Google Maps, you type it in and still it's not taking you to the right place, and you're like going around in circles and circles. You're getting frustrated, you're getting irritated, you're getting annoyed. And so that is what it is like for a person with dementia. And the confusion starts small in the early stages, and it grows and it grows and it grows and it grows as the stages progress, or as the disease progresses, excuse me. And so that is one thing to understand. So if you can imagine you being confused 24/7 all the time, I mean, my heart breaks for them. And so it's a lot more, empathy, understanding that they are having these brain changes that are happening, that one, they are no longer in control of. People with dementia cannot control the disease takes over, the disease controls them. And most of our reactions, our irritation, is in response to the disease, not to the person, right? We see the person, we don't see what's happening in here. And because we don't physically see what's happening, we get frustrated faster and irritated. But in here, these things are happening. So again, remember, they are no longer in control. The disease is in control, and our reactions are to the disease, not to the person. Okay, for some psychological things, their personality may change, or it may get, you know, not, I don't want to use the word worse, but whatever the personality is, it may
More
exemplify.
eccentric.
Depression can also happen. So a lot of people in dementia, they again with behaviors, they really, I usually send them to make sure, because they get depressed. They can get depressed after finding out this disease and with everything that's happening. Anxiety, a lot of them have anxiety, inappropriate behaviors we're going to talk about later, especially next week. It might not be inappropriate to them, it's inappropriate to us. And one example I'll give about this is that I had a patient where her mother would not, would not, but would, it would take them about 2 to 3 hours to get out of the house because she wanted to go in her pajamas. But the daughter growing up remembers her mom. Her mom did her makeup, her hair, put on nice outfits. So they argued and went back and forth. So I told her, why don't you just let her wear the pajamas? And she's like, oh my God, I can't believe you said that. And I said, well, just try it, just try it, just try it, and bring her and let me know. Well, she came back in 2 weeks on the follow-up and she was like, oh my God, we are out the door in 5 minutes. And so, you know, just changing our mindset a little, like who is that bothering, her, the person living with the disease, or us? Bothering us. And so behaviors change. Sometimes they become very blunt. Sometimes there are sexual behaviors that come out. And we just need to understand that these are changes in the brain that is happening. Some of them have paranoia, agitation, hallucination. My father closed all the windows in the house. You know, in Hawaii, we don't got AC all year round. And he wanted all the windows closed and all the blinds because he thought people were looking into the house. You know how hot it used to get? No amount of fans that we bought could make it any cooler, but whenever that was the paranoia. The hallucinations, you know, a lot of people, and I don't mean to be rude, for some people this is very hard to deal with because of religion or other reasons. But what I can say to this is that the person with the disease is living in their own reality, really and honestly. So whatever they're saying, feeling, happening is true because it's happening in their reality. They're not here in ours. And so what I mean by that is, like, if you and I were both looking at the sky and you saw it blue and I saw it as red, how would you convince me that it's blue, and how can I convince you that it's red when what you're seeing is telling you that it's blue? It's the same with somebody with dementia. What they are seeing, what they are hearing, what they are feeling is true and real to them. And so when we try to tell them, no, there's nobody there, what are you talking about? It well, it brings out, right, aggravation, these feelings, and usually an explosion and a fight happens. Until this day, nobody has won an argument with a person with dementia. Why? Because whatever is happening is true and real to them. Whatever they're saying is true and real, whatever they're feeling. And so it's just another way to kind of step back and look at it through. So my father saw people, culturally too, it's acceptable for us in Native Hawaiian culture. But, you know, and patients see them, and all I usually ask is, one, if they're safe and if they're scared of them. If they tell me that they're safe and they're not scared, I leave it alone. And sometimes they bring them with them into the room. And so if we're in clinic and they bring them and they're like, oh, Joe is here, I'm like, hi, Joe, how are you? I acknowledge him. The person with the dementia is happy, and we can move on from there. And so, you know, just a different way of looking at things. Okay, 10 warning signs of dementia. Everybody asks, how do I know if I'm getting it? Well, you can take a quick look at this graph and see if anything's on here. If you feel that you are having any of these 10 warning signs, please make an appointment with your primary care provider. And they can start the workup. I will tell you, there's a big difference between these. And the difference is that people with dementia can't, like, you know, retrace their steps. So like, I lose my keys and my phone all the time. All the time. And like now that I'm on call, I always have to have my phone. And, you know, I put my phone down and I walk away. And so I'm always having people like call my phone at home. But if you can retrace your step, right? Oh, I was in the kitchen. Oh, I was in the living room. You know, you can usually find it. Another thing is parking. People are always telling me, oh, I can't remember where I park. I tell them, well, neither can I. Like I literally take pictures, you know, from the elevator. Like I'll take a picture on my phone of what level I parked at so I can remember how to get back there. Like they got animals now and stuff. I still need to take a picture. When I'm at like Sam's or Costco, I still stand at the front and I'm like, oh my God, where did I park? and like travel up and down. So I don't know. Do I have it? Maybe if this is already starting, probably not. It's just that, you know, the most of us though can retrace our steps, right? Oh, I didn't park all the way in the back. I parked more towards the front. And so that's really a quick way of, am I really having these symptoms, or, is it stress or just something else?
So we're
Okay, so
almost 10 o'clock, Pokey. Are we going till 10:30, or would you like to start some questions?
no, I want to keep going.
Keep going. Okay.
Yeah. We have till 11, right? I know we're
No,
going to stop questions.
no,
Yeah.
not
Okay.
11.
All
10.
right. So then here's a real quick and way that we just to let you guys know our diagnosis and plan. So we do a history, right? A physical exam, a laboratory test. We run a lot of labs and scans looking for reversible causes, like we talked about earlier. We have the PCP. This is the care team, a primary care provider. And I always suggest people get a geriatrician on board, right? They're the specialists in the age of aging, as well as very knowledgeable about dementia, Alzheimer's, and then especially in the beginning to get a neurologist on board. And then your care team. Your care team isn't only your medical care team. That's your family, your friends, your supportive, your faith community, people you go to the gym with. All of that is your care team. And then when we're looking at, understanding, acceptance, education, this is really where once you get this diagnosis, we begin to understand the disease a lot through education, the Alzheimer's Association, reaching out to other organizations. In the community, I teach Savvy and dealing with dementia along with Kathy. And, those programs are great because my education and training was a great backbone, but it was really, especially like Savvy, that really gave me the knowledge on how to be a caregiver. Like I so wish Savvy had been around when my father got his diagnosis. So many things I would have done differently. We're looking at safety is always the biggest thing uh, when we're talking about patients. That's always the first priority. Know your resources. Please ask for help if you're a caregiver. We really need to prevent burnout because a lot of our caregivers are ending up in the hospital first, wiping out, and some even pass before the person that they're caring. And on that note, it's always to have a backup plan if you're a caregiver or a person with the disease on, who to call or who to take care of you, what's going to happen if something happens to your main caregiver. So I just want to say very quickly, I know we started a little late and I will give time for questions, but we might just go over a little bit of the 10:30 mark for questions. So I'm not going to go over everything on this slide, but these are many of the treatments that everybody is very well familiar with. I've done a lot of these on there. I use music therapy. I take, like you saw in the picture, taking dad outside so he's not in the house or the bed all the time. Personally, for myself, I use Western medicine and La'al. I am a La'al student at this moment, learning about that. So I use dual. I also use other therapies, such as under the other box. I was saving that for things like occupational therapy, speech therapy, physical therapy, massage therapy. These are things that are not brought on board generally when a person is get diagnosed, especially as they're progressing into the middle and to the late stages. And so I highly encourage, if you have someone at these stages, to bring them on. They will come on. You just need to ask the provider to write for this, and they'll come and do what they call functional PT and OT. So my father, about every 6 months, every time there's a major change, I have them come back in and do an evaluation, and they teach how to, what specific exercise to do. And the main reason is in the end stages, they start to contract. And so many people will notice the hands go in or they go that way and they start turning like this. Well, when you need to move these arms to bathe them, to do things, it can become painful. The nails will go into the palm. And so PT, OT will come in and show how to do exercises to keep it more limber so there's not as much pain, so they're not uncomfortable. So just keep those kind of things in mind. Okay, we're gonna go a little fast, and I apologize for that because um, I started a little late, unfortunately. So the types of dementia that we're talking about, and really quickly, Alzheimer's disease. And we're gonna talk swiftly about, this one is most associated with the short term and the long term, right? How come mom, still remembers things from the past, not from the present? Well, that's because of repetition. Those are things that they did over and over and over for years, and the short-term memory is what's being affected. So vascular dementia are things like a brain injury, problem solving, slowing things. The frontotemporal um, is more associated with language and behavior problems. Lewy body and Parkinson's are not the same thing. It depends really on what cluster of symptoms started first. And the Down syndrome I throw in there because I don't think a lot of people realize that people with Down syndrome are at a very much increased risk of getting dementia, about 50% increased risk. And so these slides that we're going to talk about, I'm going to mention the challenges for a person with dementia. The caregiver considerations will be next week if you come back to join us. So again, like we were talking about Alzheimer's, it's the loss of recent short-term versus long-term. And that's just because they were able to do it. So if they cooked their entire life, if they were an athlete, those are the things that are ingrained forever. And we will talk next week about, what to do if somebody was a construction worker or gardener, things like that. So gradual loss of long-term detail and eventually all memory will fade. Languages, this is when they start having the difficulty, when they may start confusing words, unable to find the word, using the incorrect word, or maybe sometimes babbling. And so at this point, it's really the caregiver, our job, your care team, that we really got to start looking between the lines because they really are speaking to us and telling us something. We just have to figure it out. And they might be using the wrong word, but we can listen to them. There's truth behind those words. They are really telling us something. So never dismiss something that somebody with dementia is. Oh, she just doesn't know what she's talking about. Oh, this and that. Oh, mom, be quiet. That's not, no. Um, Whenever they come into clinic with me, I, even if it's a story that makes no sense to me, yes, I let them tell me their story because somewhere in there is something that they're trying to tell me. And now I just need to figure out what it is. Reasoning, again, this is what a lot of people, and again, it comes from the goodness of their heart, professional or family caregivers want to reason with the person, want to explain to them why they shouldn't do something, why they can't do something, why they need to do something, why they need to go over there, why they need to go or come here. And so reasoning is one of our abilities, or the abilities that begin to decrease. And so it is not important to reason with them anymore because one, they're not going to remember, and two, it's just made for an argument. Now in the early stages, a lot of these things we're going to be talking about may still be possible to explain, to remind, to refresh, but understand that as the disease progresses, it won't be. And so trying to always explain to them just causes a lot of irritation, aggravation, and understand that they know that changes are happening to them and something is happening. So this is something that we really try to stay around. It's a recorrector. Mom, it's not Friday, it's Monday. No, that's not what happened. That's not what happened when you were 12. That's not what happened. Um, those kind of things are not important. If they think it's Friday, cool. It's Friday. If their story now was banana bread, now it's guava bread, we're all good. It's not anything that is drastic for us that we need to correct. Judgments, they start making poor choices. Leave the stove on. My father, for some reason, left the water on all the time. Like he would go in the kitchen to wash the dishes and just turn around and walk away. And the water would just like overflow. One of our saddest moments through this journey was, I mean, it's not cool that the water would flow, but we used to crack jokes like, hey, we have a swimming pool in the house now, and, just have some fun with it. But my father made a lot of Hawaiian weapons. And so one of the saddest moments though was his judgment. Safety was an issue. We had to take him away because we came downstairs one time and he had the drills going and he was confused and he didn't really understand anymore how to operate them and was just about to do something that would have caused a lot of physical damage to him. And so, those kind of things that we have to do when those times come. Okay, their perception, their suspicion, their paranoia. We talked a little bit about those. It happens, it comes with it. He was paranoid. We just kept the windows closed because if we opened them, it would just really infuriate him. So we learned how to just kind of deal with that. We'll talk more about understimulation next week, and a lot about this overload that happens with them, because sometimes we like to throw a lot of information at them and we have to kind of understand the stage that they're at, that it may be too much for them, that we know before they could handle all of this, but now it's just too much information. We need to just kind of bring it down a little bit. And so the perception overload, it can be, your hearing, your eyes, the environment, the people, So just to keep those things in mind. Abstraction. Now, this is more of actually um, the examples I was using earlier. So we talk a lot about abstract, right? So for us, we say things like, "Oh, next week Sunday we going uncle's house." For somebody with dementia, abstraction becomes something they can't understand, and so we don't really need to tell them next Sunday we're going to uncle's house. We just tell them on Sunday we're going, because they can't. They don't always grasp that time difference, and so they may get ready right now and then want to leave, and then get frustrated and irritated when you tell them that you're not going. And so we don't use a lot of time, distance, these kind of relationship sentences. We talk to them more in a concrete, right? What do you want to have for dinner tonight? No, we just say we're having hamburger tonight. What You open up the closet door. What do you want to wear today? Right? There's like 10 million things in there. So you just want to pick out two things. Do you want the red shirt or the blue shirt? It still makes them feel that they are in control. They are able to be independent. They can still pick their things out. But we want to understand that sometimes opening the closet door is too much for them. Okay. Attention. They have a lot of difficulty staying on task. They get easily distracted. And so sometimes we do things like we will have them sitting, on a desk facing the wall. It's not to be mean, it's just so that they can focus in. It's kind of like when you think back to when the kids were young and they were just, right, it's like squirrel, and then attention changes and they're off onto something else. And so, of course, organization challenges are a big deal, right? A lot of people who are very OCD and organized and had everything set up are not that way anymore. And so we have to be able to acknowledge that and recognize that and kind of jump in when they need the help. All right, round two, because let's wake up a little bit. That was a lot of talking. Okay, in your chat box, because we're almost done. We're right around the corner. Please enter one type of treatment that we use to treat dementia.
Pharma, therapy, drugs, therapy, pharma, PT,
Yep.
exercise, special diet, meds.
Thank you, everybody. And I want to say I didn't spend time in it, and I apologize for that. So we do have medications that we can use, pharmacological therapies. And I want to let you that none of those therapies, right, Namenda, Aricept, or even our combo meds, none of them will cure or stop the disease. Some of them at best will slow the disease down or take the person back maybe a few months, but they will not work forever. The disease will still progress, because why? This disease is progressive and irreversible. We talk about non-pharmacological ways of doing things, and those are anything that's not medication, like our music therapies, the therapy that you guys are mentioning, when we're talking with them, when we're taking them out. So there is a lot of therapies, and actually most of this we would talk about more next week.
Let me
Okay.
get one more, patience and understanding.
Yep.
Somebody put that as an answer. Okay.
Yep. I can see that one too. All right. Tell me one diagnostic tool that we have.
You.
Thank you. Now I'm just one piece to the puzzle.
You guys can answer though. What are some of them?
Yep.
Brain scan, physical exam, imaging, lab tests, paper tests.
Yep.
Yep. You got a good audience here.
I
PCP.
do. I know a lot of them.
Listen.
Things. That's right. So we went over some of them, the labs, the scans, the tests. Some of you may be familiar. We do an MMSE, mini mental status exam, where we ask a bunch of questions. We ask them to draw clock for us, and based off of that, it kind of gives us a determinant. There's other things besides the MMSE, right? We use the MOCA. There are other tests, written tests that you might have seen when you go in to the doctors that they've done. Most people are familiar with the MMSE, right? What year is it? Draw me the clock. Repeat this sentence after me. 100 minus 7 again. Say these 3 words. And then we give them 3 words to remember. Then we ask them again. And so those are just tools to help us. There is no test that we just put you in and then it like writes it out and says, oh yes, dementia, Alzheimer's. So everything that we do, from the history to the listening to the talking to the family to the talking to the person, from the labs to the scans to the blood work, everything that we do paints a picture for us that we then all take in together, and then we say yes, this is a diagnosis. If they're, neuropsychologists are not that prevalent here, but they are wonderful tools to have onto this, because that report is amazing. I will say that the Alzheimer's Association and their research department does not feel that they are far away from having, treatment or even possibly a cure. Now let's hold it back when I say that. There's still a lot of work to be done on that. We are getting better diagnostic tools, right? We're starting to see PET scans, we're starting to see blood tests. None of this is out on the open market yet, but we are getting closer, and better and better and better at getting tools to help us diagnose, and then also working towards getting that cure for everybody that has this disease. Okay.
Are there examples of the tools they can get? Is one of the last questions.
Okay, we'll do the questions. The tools to diagnose. To diagnose, you'd have to go to your primary care provider. Yeah, okay. Or your geriatrician. We would have all the tools that we need to diagnose, and we will greatly share them with the family. It's a very open. We go over everything with the family and the person with the disease, so you will see all of it. You will hear all of it. You will see all the results. You will know all of it. And then one of the last questions: true or false? Are you responding? Well, is it true that you are responding to the person? Or are you, what I mean is, are you responding to the person or the disease? So true or false? Are you responding to the person?
True, 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 both. No, to the person. The person, true.
You're responding to the disease. And that shows me I did not explain that clearly, so I apologize.
Not to the person,
Yep.
disease.
Disease. Okay. So when somebody has dementia, you're responding to the person, that repetitive questions, those behaviors we talk about, and our reactions, we react to the disease because why? The disease is in control. The person is no longer in control. The disease is. And we are responding to the disease. What is coming out of their mouth, the behaviors that they're doing, the way we're feeling, happy, irritated, aggravated, sad, mad, frustrated because they asked us the same question for the 20 billionth time. That is we are all reacting to the disease, not to the person. That person has no control anymore over any of that. It is the disease who's controlling it all. Okay. All right. So thank you for playing, because we have to stop and have some fun sometimes. So let's move on. So this you can find online too. This isn't the full report. The Alzheimer's Association releases a report. The 2020 full report is here. You can go to their website. You can just Google it in and download it. This is a very quick, letting us know that this is the 6th leading cause of death here in the United States. There's a lot of, I'm not going to go over all of these facts and figures on here about the money that we're spending, about the lack of knowledge within my own community with my colleagues, and the association is spearheaded, to kind of rectify this, because, especially for our Medicare, there is actually a code that we can use that is specifically used for dementia training and education for family, and about only 1% of providers even use it to this day. So we do know that in Hawaii, we have 29,000 people living with the disease. We know that that is a most likely an underestimated number because of reporting. And we have about 66,000 caregivers. And we know that number is rising. Within just a few years, we are expecting to have 35,000 people living with the disease. And so that is why so much education is going out. There's a movement called Dementia Friends that started out in Europe. And it's not looking at just training family and providers. And these are why these webinars are so important. It's not just for the professionals in the family, because everybody, whether you work at a bank, a supermarket, on the bus, you will come into contact with people with dementia, and people on every walk of life need to understand dementia and how to respond to it and how to address the behaviors. And so with this movement in Europe, they are training people in the banks, bus drivers, people at the supermarkets, to be able to identify people with dementia and then be able to address how to help them, because essentially helping them is helping us too. And there's a great video that, if I have time next week, I will show you guys on that depiction. Okay, so we're gonna talk a little bit about COVID right now, because people keep asking, how does it affect it? All of these questions. So I'm gonna go over this a little bit quickly, ask questions at the end, and I will do my best to answer them. So dementia does not put anybody at an increased risk to get COVID-19. Dementia does not put you at risk of getting COVID-19, does not put your loved one at risk. What puts your loved one at risk, or you at risk, is your underlying medical conditions. For anybody out there, it puts anybody at a higher risk if they contract or get into contact with COVID-19. And so somebody who is diabetic, somebody who has cardiovascular disease, because most people with dementia have other underlying disease. It is those underlying diseases that will put you at greater risk. Should we tell them about COVID-19? That depends on how you are the best person to know how that person's reacting. Think back in life, how did they react to things like this? When there was a disaster happening, did it really cause a lot of agitation? Did they get scared? Or were they ones who were able to, like, yeah, okay, I got it, or just wanted to be very informative? So especially in the early stages, yes, you may be able to use more of the concrete terms, keep it very simple, watch when you put the TV on. For some of them, what's on TV is real. For my father, he loved war movies. We had to stop putting them on because he thought it was real. Taking him back, he was in the military. So took him back to his military days. Started doing things that I've never seen my father do before. SVU, I loved watching that show. We couldn't watch it because he thought what was happening was real. And so he would go to attack the TV. And so we had to change things like that. Will they touch their face? Understand that even though we're told not to touch our face and to wear our mask, they are going to. They're not going to remember. It is going to happen. So not to be like, oh, Mom, stop touching your face. I told you that 10 million times. Stop. You just have to know it's going to happen. They're going to touch that area. And then to take into consideration that this really is a disruption to their routines, not just to ours. All of us felt it when COVID hit, especially when we were all in lockdown. And for a lot of people in nursing homes, like at Lunalilo, I still have it on lockdown right now. We just started drive-up visits with the family, but for the most part, it's still on lockdown. That COVID-19 not only disrupted us, but their routines also. And people with dementia, routines are very, 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 very good for them. And so when their routines get disrupted, that can when agitation, hostility, irritation, all these other behaviors start to come out. So again, all behaviors have meaning. That is them trying to tell you how they are feeling and that this is very upsetting to them. So then let's figure out how to change that for them. So if they went to an adult daycare and they exercised every day at 10, put an exercise video on at home at 10 a.m. for them so that they can exercise and feel that they're still maintaining some normality after all of this change. Check in with their mental health. They may need, to go to a BH specialist. Hand washing, let's not get on them for the 30 seconds, sing your happy birthday song. If they will let you, have Purell bottles or your sanitizer all over the place, just dip it on their hand. Some family members put wash basins in their living room in different parts of the house so that they can wash their hand when they take them out. They're not going to remember these things. So we have to accommodate them. Look at what challenges they're having and think how we can circumvent that, support them and stay connected. This one is kind of a roundup of what we just talked about. And really just kind of wanted to more talk about like the food and shopping. It may not be the best idea to take them. Only you can really make that decision. And the stay-at-home recommendations. Some of my caregivers, because I do a support group for the association too, were mentioning that their loved one, the person with the disease, needed to go in for an appointment, but they could not go with them because of the rules and regulations. You can only come in with yourself. You can't bring anyone. So things that I told them to do was call the office in advance and ask them for the paperwork so you can fill it out and send it back. Ask them, because most of them all have tablets, if they will take your phone or put you on the tablet. And that way, even if you physically can't be there, you can at least still be with your person. Your person can see you and you can still walk with them, be there through the procedure, so you can talk them through it, calm them down if you need. But first and foremost, always call and let the place know that your person has dementia and that they need you to be at their side. A lot of times they will make the accommodation. And then this one is right driving in the point of what we were talking about, but I think I will move on to this side, um, because what I really want to mention is during this time of COVID, not only are we recognizing that they may not understand what's going on, and so how do we explain it to them? Should we explain it to them? How much do we tell them? And you might think, oh, they can handle all of this, and then they can't, and that's totally fine. It's a live and learn. A lot of things in dimensional this is trial and error. We're going to try something. If it works, yay, we're going to celebrate it. If it doesn't work, totally okay. We're just going to try something else. So besides us having this isolation, the person living with the disease is now been put into even more of an isolation bubble. They're having emotional feelings. Again, their routine is disrupted face to face. For a lot of them, they will know that their caregiver has changed when they're not going to the adult daycare anymore. They are now in their head confused because why is this person here all day with me? This is not the person who took care of me. They're in these different clothes. I'm in this different environment. This is not where I'm supposed to be. This is not where I'm supposed to go. And they might not be able to say this to you, but change for them is a big thing. It takes about 2 weeks for them to get used to a new change or longer. And so when we're having big changes like this, we need to be ready for it, acknowledge it, kind of have a plan on what to do, backup plans, activities for them. For some of them, they used to garden. Okay, can we bring, if you don't have a garden because they garden somewhere else, can we bring the garden inside for them? Can we mimic their exercise routine? Can we mimic their routine that they had wherever they were at before COVID started? And if not, can we make a new routine? Now, some caregivers are so happy to spend time with their loved one, and other caregivers were after 2 months, we're like, oh my gosh, all we do is see each other. So we had to kind of come up with things to change it up, play games like getting plastic bottles and putting it in the kitchen and playing bowling, drawing on a piece of
Okay,
paper.
we're going to have to start questions here.
It's not 10:30 yet. I'm almost done, Rick.
Okay.
And so, but I think these are very important things to remember when we're talking about COVID, and that we, have to be ready because COVID isn't going anywhere anytime soon, and we're going to be having more changes along with this. And so, again, just wanted to share a picture of my father and I, and we're just going to finish on. It's 10:22. I'm just going to take the last minutes because the next subject coming up is one of the biggest ones. So routine, talking about COVID, we're just wanting to finish up with saying that they do have a routine, and routine is ingrained into the head. And we know that when something happens, there's a cue, a routine, and there's usually a reward at the end. And so that's what's circling in their head, and that would help you at home to kind of redistribute what they're missing. Now for behavior, we're going to talk about what we were saying before, all behaviors mean. Now we will dive into this a lot next week, but what I really want to say is that behavior doesn't come out of nowhere. Basically, something happens, there's a behavior, and then ABC model comes out of those, they use it with autistic kids, but really it's saying that something happened, there is a behavior, and then something happened right after. And so what I ask a lot of my caregivers to do is to keep a diary and to write down for me when the behavior is happening. What time of the day is it? Who's around? What was happening? What part of the house were they in? And all of those things are really crucial because when you bring it to me, then I can read over it and flip through the pages, and I can see if there is, if there's anything that stands out to me that could be causing the problem. Like for instance, some people don't realize it's a reflection in the windows. And so they think it's somebody staring into the house. So they get mad, they yell, they go up to the window, they start fighting, or they get scared. And so if you can write down for me the behavior, what time of the day it's happening, I know the sun is coming down, it's getting dark, we could maybe figure it out. And that's a true story from one of my patients. And all we had to do was close the curtain, the behavior stopped because he no longer saw his reflection in the mirror. So it's just small things like that. Okay, so behavior, why do behaviors happen? Access to attention, access to items and activities. Sometimes it can be to escape something that they're scared of, they don't feel comfortable doing, they want to avoid something, or even sensory. They do like a lot of sensory things, and maybe they're telling you that they need something like that. So how do we manage behavior? We describe the behavior, and that's why I want the diary, and I encourage people to have the diary, describe the behavior, what happens before the behavior, what happens after the behavior. I'm trying to identify the trigger. What is triggering and causing this behavior? That is really our goal. That is what we're really trying to get at. And once we figure that out, then we can come up with a lot of different solutions. We make the plan, and then we reassess. There's only 2 more slides left. So I just wanted to point out that there are other issues that caregivers are going through. And this is we need to be cognizant of this, no matter our role as a professional, a family, or in the society, because, and I will just jump down to intergenerational employer-employee. We have a lot of families now living together, but not only that, that's been normal in Hawaii, is that we have caregivers who are 60-year-old now helping to take care of their grandmother or their mother or father who now has a disease. We have high schoolers taking care of it. And so caregivers are very able to still contribute to the workforce. And we just have to be a little bit more open and flexible. Like you saw with me this morning, to take care of what you have to do at home, you're able to do things at work. So can we do things that they can work at home half the time and then come into the office? Can they stay home so they can take care of the person they're caring for and still do the work? We have high schoolers who are getting grades like Fs because they are caregivers, main caregivers, kids in college who have to miss tests, who have to miss class so that they can take the person they're caring for to the doctors. And we need to be aware of these things because they should not be punished or be failing for these things that have to be done, that can't be given to anyone else. And the same for those of us in the workforce. I learned a long time ago, I have had jobs who it was affected because I'm a caregiver, but that is who I am. And so it very much in all of my jobs, I am very upfront with, I am a caregiver first and foremost. This is what I need, and this is what I need to be able to do my job. And I've been lucky that all of my employers are very flexible with me so that I'm able to do both. But please keep those things in mind, because sometimes when someone says they're a caregiver, it's like a negative flag and they don't get hired. And we have caregivers now in their 50s and 60s who cannot find a job because they have too far of a gap on their resume because they were a caregiver for 20 years. We have caregivers who are working 2 to 3 jobs. We have caregivers who are having to leave their jobs. So this isn't something that's going away anytime soon. And I bring this up in the presentation because it's very important to understand and know these things. And when you're a young professional trying to plan out your professional career, I had to stop working for a few years, and it was very hard to restart my career when I came back in. So just a kind of something to keep in mind for caregivers and everyone else out there. All right, and for the association, if you really want to see how the brain works and have some fun and it's interactive, you can go to this website or take the brain journey, the association, and you can highlight different parts of the brain and tell you what it does, and it's a really fun and interactive thing to do. So again, here's some resources for all of you to go to. Here we have the ADRC, Elderly Affairs Division, Hau'oli, NTG, the association. There's so many, HPGS, the Caregiver Foundation. So there's a lot of resources out here, Queens, Memory Clinic, like at the facility that I work at Kukuo'ali Valley. So there's a lot to reach out. But then again, just thank you everybody for joining me. I hope that it was helpful, that you enjoyed the presentation. If you need to get in touch with me, here's my email. A lot of people do like to email me for questions, comments, or concerns. I'm more than happy to answer you if I don't get to your question today or at any time, even if it's months away from now. You can always shoot me an email if you have a question, right? So thank you.
Would you like some questions now? Oh, where'd it go? So, okay, we have several questions. Would you like some?
Yeah, that's fine.
Where my chat box just went. Oh, it switched. Okay. Well, so somebody asked about, and you touched on it a little bit, alcohol use for somebody with dementia issues. Mm-hmm. Alcohol okay, or is that a no-no altogether?
So alcohol, there's an alcohol-induced dementia that it may possibly be reversible if uh, you stop drinking. Is alcohol okay to drink when you have dementia? I mean, just think smoking, alcohol, those are all things that we should not be doing and would decrease our risk factor. Saying that, you take into account quality of life too. I do have a resident who likes to drink red wine. He's done that his entire life. He has the disease. It's not going to, it's irreversible, correct? So one of his loves is to have spaghetti. He's Italian, and a glass of wine. And so at this point, yes, he gets his spaghetti and his glass of wine because it's more important that he enjoys his last moments than it is to prevent that glass of wine um, for a disease that is not, we can't cure and we can't stop.
Are there some medications that somebody could be on that would make it dangerous to have alcohol?
Yes, there are a lot of drugs that you should not, medications that have interactions with alcohol. And so for things like that, if you are drinking alcohol or you're thinking of doing it, then you should always check with your provider. But all of us usually are always doing what we call med recs. When the patient comes in, reviewing the meds, the side effects just automatically start going up in our head. And so if you let them know you or the person is drinking alcohol, we'll be able to see, if there's any interactions and it shouldn't be done.
Mhm.
And saying that, we may be able to change out the medication if having that glass of wine is that very important.
Some medication that actually could diminish the effect of the medication if you're doing alcohol also, not just a side
Yes,
effect.
correct.
So another question is seemingly excessive sleep a part of dementia?
Yes. So, and when I say that, now let's be careful because depression can make people sleep longer too. So this would very much depend on the stage that they're in. Also, other diseases, other medical issues could make somebody sleep. So when we're talking about this, questions like this, always take to the provider. Your provider knows the case or the person really well and can see if there is something that we got to look into, or is it just a disease. So my father is only up for 4 hours a day now. He's asleep by 8, and I'm lucky if he gets up at 2. Really, he gets up at like 4 or 5. He's up for 4 hours. He's back down sleeping. As the disease progresses, they will sleep longer and longer and longer.
And true for most end of life things, as it progresses and gets towards the end, people sleep quite a bit.
Yeah.
But you do, like Dr. Mentioned, you want to check for depression and things like that also. Somebody earlier asked, speaking of end of life, and I'm doing compassion and choice now as well as a volunteer thing, but they asked about end of life, the option, our choice, death with dignity. Is that an option for somebody with dementia?
No.
No.
So the end of life choice is not. Hopefully, maybe someday that will change. And the reason is because when you read medical aid in dying, the person who has the disease has to be able to administer the medication to themselves.
Right.
And they need a diagnosis of 6 months or less. Now, if they have other ailments and other things happening besides dementia, you may be able to get that order. But by the time that 6 months diagnosis is most likely true, the person has lost the ability to understand, to think, and to be able to give themselves a medicine. And so that's what, it's not the only, it's a whole big thing that we could have a whole nother 2-hour discussion on.
Yeah.
But basically that's it, because a person would not be able to understand and then pick up the meds and give it to themselves. And you cannot, the family member cannot give it to the person for them.
Yeah, there's no assisting, and they have to be competent. Otherwise, there could be all kinds of things that could come up. Okay, another question is, does electronic magnetic field device in the room slow down dementia? It's supposed to rejuvenate your blood cells and to flow smoother. Okay.
So again, I will refer to saying things like, you can read medical journal, know where your source is, that you are getting your information. And the reason why I don't always refrain from answering so much questions when we're talking about maybe alternative therapies or therapies that people want to use is because to some point, and this is my opinion, some of my colleagues who are listening may be like, what? At some points there is some kind of placebo effect, whether something is working or not, right? When you believe in something, I mean, we have studies that show that people, who believe something get better than the ones who don't. And that is a whole nother discussion. And because there are cultural remedies, there are so many therapies out there. What I do say that is if you are using things like like electromagnetic field, if you are using Chinese medicine, Hawaiian medicine, whatever you are using, devices, to just please let the provider know. The geriatrician, hopefully everybody has a geriatrician on board. Everybody should, even for yourself if you're getting older, or your primary care provider. Just let them know, because you can have that discussion with them, and they need to know so that when they are suggesting therapies or medications, if we don't know, then it could have a detrimental negative effect. So please bring those things up and have that discussion.
Okay. So here's a pretty interesting one. Kind of falls into the mental health field a little bit too. If my dad is trying to catch a plane every day and trying to reason with him agitates him and me, I can't just agree with this behavior. Do you have a recommendation?
You
How to
can
handle it
agree with
better?
the behavior.
What
You
if they're
don't
going out the door?
You don't have to disagree. So that's when we talk about next week about
Okay.
distraction and reorientation, because you've answered your own question. To disagree turns into an argument and becomes agitation, which only hurts the person with the dementia and you, and then makes that explosion happen. So try something else. Don't do that. If a lot of times, a lot of patients we have want to go home after they've been moved into a nursing home, or they move in with their children. They want to go home, or they want to catch a plane. They want to get on a bus. What sometimes works, and it doesn't always, is that we put them in the car and we take them on a drive for 5 minutes. Sometimes it's really just around the block. Sometimes we take them for 15 minutes. We bring them back to the house. They think that they went home, or they feel that they're coming, and it works. Now, depending on the part of the disease, you may have to do this quite a few times. What you can also do is do things like, print out a boarding pass, a fake boarding pass, make one and say, no, your flight is tomorrow. Look, Dad, it's tomorrow. Look right here. If they can still read and understand that. You can say things like, no, we're going tomorrow. We're going in 1 hour. Just give me 1 hour, Dad, then we're going to leave to the airport. Get some luggage. Put some luggage by the door so that, yeah, he thinks he is going. Pre-pack it, put it in the car, take him in the car, bring him back out. A lot of things that we do as caregivers and professional or family takes a lot of our time, but it's really to respond to them. And then honestly, what is that? Why is he getting like that? You would probably have to email me. There's so much more questions I have. Was this part of his job? Was it the regular thing that he did? Did he always catch a flight on Fridays? If this is a routine that has been part of him in his life, then this is something that's not going away. Then in his mind, he knows that he's supposed to be catching a plane. So can we bring out books or pictures from his past flights? Is there a way to for you to drive him in the car, then come out and pull the bags out of the car and say, "Okay, Dad, we're home. I just picked you up from the airport," and then carry those empty bags back into the house with him. So a lot of these things are thinking outside of the box and figuring out how to turn our world into their world.
Are animals, dogs or cats, good company? Pets?
Yeah, pet therapy is amazing and they love it. So as long as it's safe, they have their shots, and there's a lot of hospice, do pet therapy. We put food out and the birds fly all over our fence, and my dad loves it.
Is it important for somebody with Alzheimer's to get a flu shot?
Yes.
Right. Let's see here. Is there a state law that those in care homes need to give? Oh, you just did that. Do they have to have them if they're in a care
A
home?
flu shot?
No,
Yeah.
I think they mean is the care home responsible for giving them the shots, and they are not.
Oh, they are not. Okay. Let's see.
And I want to tell everybody for the flu shot, please get the flu shots, because a lot of us are worried about the flu season coming, especially with COVID still here, and we are ramping up too. And so I would just advise to please go get those things as soon as possible if you haven't already.
Where can I find an interpreter to talk to the caregiver for my brother to help understand all this info on dementia, etc.?
What kind of language do they speak?
I'm not sure. David Tom is asking that.
So there are your provider can
Korean.
So we do have interpreters. Like if you come into the office, we can all call interpreters over the phone, that can help us while we're in clinic talking so that everything can be explained. In fact, can you email me, David? I did get from the association just recently the flyer for Korean, for people living with the disease or caregivers. It was all in Korean, led by someone who speaks Korean, and then I can forward you that information. You can link up with them.
Should you include the dementia patient in the discussion of care? Talk with them in the room, remove them from the room when you're doing meetings.
That really depends on the person. Hold on real quick. I'm gonna write my email in because I took down the slide. Like at the association, we prefer, well, you're not allowed to bring the person with you because some people get agitated if they hear their loved one talking about them. That's because, like any of us, nobody wants to be talked about in the room as if you're not there. And sometimes they can't understand what's happening, and then it can turn into an argument, like, I don't do that. But at the same time, if you're asking me, should the person be told about their diagnosis? I will usually ask the person if they want to know. I do feel that they should know. And remember, just because they get this diagnosis in the early stages, they're still very much able to make all of their decisions for their health care and everything else they need. So I will always ask the person with the disease, no matter their stage, what they want first. And then I will speak with the family about what to do, because they do still have the right to dictate their care.
Sure. At the age of 87, my mom is showing mostly forgetfulness. If changing her diet at this point, will it slow it down? No, we've kind of talked about that one, yeah?
So it doesn't hurt. That's what we tell everybody. Once you have the disease, we can't reverse it, but everything that you do to keep it, can help to slow it down and progress it. Now, just to make sure, if you're saying your mom is getting forgetful, let's not just, say that it's this disease. Please take them in for a thorough workup.
Okay. In future sessions, will strategies or tools caregivers can use with dementia patients be discussed?
Yes, that's all next week.
Yeah, and mine is all, so on August 1st, my mental health one is all about strategies and tools. That's all we're going to talk about. Let's see, what is this?
So this one was dementias, and then next week is caregiving, one-on-one, all about you. So that's where we'll address behaviors and, like you're asking, strategies and how to handle it and what to do and all of that.
We live in the Big Island now for 5 years. And so I think things moving. You get a lot of questions coming in here. And so I think he forgets. Let's see. Okay. So they moved and they think that their parent forgets. What can they do about that? And mahalo for the advice. Let's see.
Is that from Pua? Hey, yeah. I guess. Oh, no, you can turn your speaker on.
Give mahalo to daddy and mommy, please.
I will. No, I saw your picture. Sorry, everybody. My father was in Hau'oli, and his father, Akuli Keke, was oh my gosh, my brain is going alohe, and he was a graduate. So, anyways, that's why I was. So when I saw the last name, I saw Pua Polygon. I was like, and then I looked at the box. I was like, oh my goodness. So, okay, sorry. What was the question?
That's their question. You guys can talk then.
No. Pua said we live in Big Island now for 5 years, and so I think he forgets. Oh, yeah.
I had switching the plane question.
Oh, okay.
Catch a plane every day, so that was just mahalo for the advice. That was great.
Okay.
Yeah, and then email me if you need.
Pack one bag and put it in my truck.
Yeah, it's like that. Or just call me too. You can call me.
So Kathy, it looks like we're recording now. Will the recording for these sessions, where will they be posted? People are asking. You see that question?
Who has my number? Just
I'll post what we have, and I'll let everybody know by email, because I have everybody's email now,
Okay.
where it will be posted, where they can find it.
And then the last question we have is, should you include the patient in the advanced healthcare directives? It's kind of similar to the earlier question, but.
Yes, you should. And now that, especially when we're talking about COVID, we were really spearheading, catching up with all of our patients who don't have one. And so what we would like is for everybody 18 and over to have an advanced health directive, and to please have the discussion with the person living with the disease before they are unable to tell you what they want. that would be the best way for you to carry out their wishes, and for us, us providers also. You also want to make sure that you start getting your paperwork for like power of attorney before they lose capacity. Remember, just because a person gets dementia, you don't automatically become their POA, and all of those. That paperwork needs to be done. What happens after, if you don't do that paperwork first, is the provider, needs to write a letter of capacity saying that I feel this person can no longer has the capacity to make their decisions, blah, blah, blah. But the only person who can make that ruling is a judge. So then it becomes a long process to get a letter from me of support, to then take it to a judge, to have the person declared incompetent, and then for you to become in charge. And if there is nobody assigned to that role, we have a very difficult time, because we can't just release information, and that person is still the person to make their decisions. So they're not competent anymore, but they're still going to be the ones that we have to listen to. And now that we're in the COVID time, we are asking all caregivers to have a backup plan. If something was to happen to you, who's the next one to take care of the person with the disease? Who is the next? What's going to happen? Please write out their meds, what they like. If the person was to get the disease, what is the next steps to happen? Because you have to think, if you get it and now you're in the hospital, who's going to take care of your loved one? And that's always what I tell caregivers, even before COVID. Always think about it that way. And we'll talk about self-care next time.
That's all the questions.
Okay, I'm going to thank you, Rick, for moderating. So many good questions. It looks like that maybe I should have made these sessions longer because there's so much information. But I will probably add time to the next Zoom meeting. So if we go over, you'll be able to hear everything. And we'll make sure it's recording as well. So next Saturday at 9 a.m., I'll let you clock in at 8:45, or start clocking in then, and get you into the workshop. And if you have any more questions, give me a call. You've got my phone number in my email that I've been sending to everybody. Thank you so much for sticking around. There's still 56 of us on the call, so I appreciate your interest, and we will see you next week. Thank you so much.
Thank you, everybody. Bye.
Bye.
Thank you, everybody. Kathy,
Rick, Kathy, are we staying on?
what's
or-
that?
Are we staying on? Or
Yeah.
are we- okay.
Yeah.
Yeah.
So Kathy, you are recording.
Oh, I can unrecord now?
I think so.